Well, hello everybody. I am Paulo Savoia. First of all, I'd like to thank the WFUMB for the invitation, especially the President-elect Maria Cristina Chamas. It is an honor and a pleasure to talk to you today. I will talk about basic concepts in lung ultrasound. Okay, so first of all, we have to understand that gas, air, is not well characterized by ultrasound. Therefore, normal lung parenchyma is not visible on ultrasound. Normal lung is filled with gas, with air, and it cannot be seen normally on ultrasound. We will see only the thoracic wall to the pleura, but beyond the pleura, we will not see the normal lung. Okay, the pleura will be a hyperechoic sliding line in phase with respiration. Okay, and from it and from artifacts generated by it, that much of lung ultrasound is based. Okay, so let's start with some practical things here. First of all, if we have our patient laid down like this, okay, we can imagine his ribs. Okay, so if you place your transducer in this position perpendicular to the patient's ribs, you will have an image like this. Okay, so this is the basic image of lung ultrasound that you have to search for. Okay, so in this image, we have the chest wall, we have the ribs acoustic shadows, and we have the pleural line, which is this hyperechoic line that will be sliding with respiration. Okay, so this is the basic image that we have with the curved transducer, the low frequency transducer. Okay, usually I do the exam with the curved transducer, the low frequency transducer, and then if I have to see well something, I change to the high frequency transducer, as I will show you some examples. Okay, so first of all, the first thing you have to look for in the intercostal space, you have to look for the A lines. Okay, so the A lines, they are horizontal lines parallel to the pleural line. Okay, so these are A lines. Okay, these are A lines here. These are A lines. Okay, they're artifacts. They do not exist. Okay, they're artifacts of the pleural line. Okay, so depending on the patient biotype, if the patient, for example, in this case, the patient is very thin, you have more A lines. This patient is a larger one, you will have less A lines. Okay, and they represent normal aeration. Okay, when you see A lines, it represents normal aeration in the periphery of that spot of the lung. Okay. Then another thing you can see is the B line. Okay, so B lines are vertical lines emerging from the pleural line. So this is a B line here. Okay, they are hyperechoic. Is a comet tail artifact. They are well defined and extend indefinitely until the inferior border of the image. Okay, they move with the pleura as long as the patient breathes. You can see it moves with the pleura. Okay, erase the A line. So here you have an A line that is erased partially by the B line. Okay, and they represent thickening of an inter and or intralobular septa. Okay, so let's understand this better. Okay, to understand this, we have to think about the secondary pulmonary lobule, okay, which is the smallest functional structure of the lung. Okay, it has about 5 to 7 millimeters, and we have here the central lobular structures, basically the distal artery and the distal airways. Okay, the distal bronchi and the alveolum. Okay, alveolum here. These are the central lobular structures, okay? But let's forget about the central lobular structures, okay? Let's focus on the periphery of the pulmonary secondary lobule. We have the septum, okay? These are interlobular septa, okay? So each secondary pulmonary lobule, they're limited by interlobular septum, okay? And we also have the intralobular septum, okay? Which is a net of septa inside the secondary pulmonary lobule, okay? But what is in this septa? We have basically interstice. And in interstice, we have three things, okay? Veins, lymphatic vessels, and connective tissue. So if you have a condition that affect veins, lymphatic vessels, or connective tissue, you have your septa thickened, and then you have the B lines, only if it is in the periphery of the lung, okay? 1 or 2 by intercostal space we consider normal. More than that we consider not normal, okay? So let's see some examples here, okay? So in this example we have in the CT thickening of interlobular septa, and if you place your transducer right here, you'll have B lines regularly spaced one from each other that represent the secondary pulmonary lobules, okay? So these are the septa thickened, okay? Another example, this is a beautiful case from Yoshino Sameshima. She saw in a small child here thickening of interlobular septa. You can see B lines here regularly spaced in the case of edema, congestion of the lungs, okay? Another example, interstitial disease. When you have reticular opacities, the connective tissue is affected in this condition, and then you have B lines irregularly spaced one from each other, okay? So you have a lot of B lines here. You can also see an impairment of lung sliding because of the interstitial disease, okay? The lung is not sliding as it should be, okay? Another example of B lines, okay? But you also can have the confluent B lines, okay? Confluent B lines, they have the same characteristics of the B lines, but they are thick, okay? It's a beam of B lines altogether, okay? So they will be well-defined, they will go extend indefinitely to the inferior border of the image. It will erase the A lines, but will not be only a line, a thin line. It will be a thick line, okay, a beam, okay? But what represent the confluent B lines? The confluent B lines represent the CT ground glass opacities in the peripheral lung, okay? So if you have ground glass opacities in your periphery of the lungs, you will have confluent B lines on ultrasound, okay? So it's just like this. You can see B lines, but they are not thin as the traditional B line. They're thick B lines, or as we call it, confluent B lines representing the ground glass opacities in CT. We know that ground glass opacities have a huge differential diagnosis. In COVID-19, it's been appearing a lot, so it is very important to know the confluent B lines, okay? Here are some examples. This is a patient with COVID-19 confirmed, and this is in the ground glass opacities here that you can see on CT. If you place your transducer right where ends the ground glass and starts the normal lung, you will see confluent B lines and then A lines here showing the normal lung here, which is this part of the lung, and the confluent B line, which is this part of the lung with the ground glass opacities, okay? If you have an extensive ground glass region in the CT, you have an extensive confluent B line in ultrasound, just like in this example. If you place your transducer here, you have confluent B lines, very extensive, just a little bit of A lines here when the patient, depending when the patient breathes, you can see a little bit of aeration here, but you see a lot of confluent B lines, which is when you place your transducer just right here, okay? And what about the crazy paving? So we know from CT that crazy paving is ground glass opacities plus inter and or intralobular septa thickened, okay? But in ultrasound, if we try to see the crazy paving, just like this, we have crazy paving here, ground glass opacities with inter and intralobular thickened of septum, okay? If we place our transducer here, we will only see confluent B lines, okay? Just like that. If you place here, you will see this image, a lot of confluent B lines, okay? So we cannot differentiate by ultrasound the crazy paving from the pure ground glass, okay? So pure ground glass and ground glass with inter and or intralobular septa thickened cannot be differentiated by ultrasound, okay? Crazy paving is also appearing in these COVID-19 cases, okay? And we have the false B lines, basically are two of them, the E lines and the Z lines. The E line is from emphysema, okay, emphysema, and it appears when you have subcutaneous emphysema. So they are well-defined, vertical, erase the A-lines. However, they do not emerge from the pleura. They emerge from the subcutaneous tissue. And they are not synchronized with breathing, okay? They're kind of stopped there. And you also feel some crepitation when you do your exam, okay? This is an example of a false B line. The other false B line is a Z line, okay? The Z lines, they're important because they're detected in about 80% of the patients, but they're artifactual, okay? What are the Z lines? Z lines are similar to confluent B lines, okay? It seems like a confluent B line, however, it do not erase the A line. You can see here the A line is not erased. They are not well defined, okay? And they may not synchronize with breathing, okay? So it's difficult for who is starting to do lung ultrasound, but Z lines are artifacts, okay? Please take care. Do not call a Z line a confluent B line, okay? So be careful. We also can have pulmonary consolidations, okay? When you have a consolidation, you will have the gas of your lung replaced by fluid. So it gets characterized by ultrasound. The gas comes out and the fluid comes in, and then you can see by ultrasound as long as there is no normal lung in between your transducer and the consolidation. But then consolidation will be a structure with echogenicity of a tissue, hypoechoic, apparently solid, okay? They may be small and peripheral or extensive, like in lobar pneumonias, for example, okay? And they have hyperechoic foci inside, which are the air bronchograms. And they usually are dynamic in consolidation, especially in the huge ones. You can see the air bubbles coming in and out the air bronchograms. Okay, so these are some examples. This is a small peripheral consolidation. You have the pleural line here. You have the small peripheral consolidation here. And you have this line, which is not a B confluent line. The line that arises from a small consolidation, it's called the C line. Okay, it is not ground glass. And you also can have a huge consolidation like a lobar pneumonia in this example, when you have a huge area of hypoechoic tissue with air bronchograms, which are these linear hyperechogenic structures inside. Okay, you can also have small peripheral consolidations, just like in this example. This is a COVID-19 confirmed patient, and you have small peripheral consolidations here, 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 and here. This is the CT of the patient, okay? When consolidations get a little bigger, for example, this is about 4 centimeters, a little more than 4 centimeters, you can get to see the air bronchograms inside, okay? If you change to a high frequency transducer, as I said before, to study better some areas, you can change your transducer to the high frequency transducer, and you can see, well, look at how beautiful this image is of a consolidation with a lot of air bronchograms inside, and you can also see vascular vessels here, okay? So this is a beautiful image. About atelectasis, atelectasis is very similar to pulmonary consolidations. You will see tissue echogenic structure, may have air bronchograms. However, it tends to have size reduction. Okay, so you will see something like a consolidation. However, it comes with size reduction. Okay, you can see kind of a collapsed image, just like in these two cases. Okay, so this is an atelectasis. This is an atelectasis. It comes with size reduction. You can see air bronchograms inside. Okay, you can see air bronchograms inside, but they are usually static. They do not move as in the consolidation. Okay. What about pneumothorax? So pneumothorax is when you have gas in pleural space. So if you have gas in your pleural space, you will not see the pleural line moving, because the gas in the pleural space will not allow you to see the pleural line moving. Okay, so if you see a stopped lung, a lung that apparently is not moving, think of pneumothorax. Okay, the lung will be moving. It's not that the lung is not moving. The lung is moving, but you are not able to see the lung moving because of the gas in pleural space. Okay. So another important thing is, if you see a B line, you can exclude pneumothorax, because if you see a B line, you are seeing the septum. If you see the septum, there is no gas in the pleural space because you can see the septum. Okay, and also another concept important is lung point. Lung point is the transition point where pneumothorax starts. Okay, I will show you some example ahead. And the documentation is with the M mode. Okay, so this is an example of pneumothorax. Okay, if you have a normal lung, you have the chest wall not moving, and you have the lung moving. If you place your M mode here, you have no motion in the chest wall, and you have motion in the lung, causing this disappearance that is called waves on beach or seashore sign, like if this is the sand and these are the waves on the sea. And if you have pneumothorax, the gas in pleural space will not allow you to see the lung moving, so it will appear that the lung is not moving. So when you place your M mode here, you will see no motion of the chest wall, but you will see no motion of the lung as well. So you'll have the barcode or the stratosphere sign, okay? This is an example when you have, where you do not have pneumothorax, you see the seashore sign, and where you have pneumothorax, you see the lung apparently not moving, okay? And this is the lung point, okay? Look how beautiful this is. In the intercostal space, you see that half of the lung is moving, but the other half of the lung is not moving. So this is the lung point, is where the pneumothorax starts. And about pleural effusion, we know that ultrasound is very good to detect even small amounts, 3 to 5 millimeters, it can be detected. Radiography is only more than 50 milliliters. But to quantify the pleural effusion, ultrasound is not so good. To qualify, it is good. We can see debris, septum, loculations, or nodules. Okay, these are some examples of pleural effusion. No secret here. You see liquid anechoic structures. Okay, this is a big pleural effusion here. This is a loculated pleural effusion here. You can see well the parietal pleura and the visceral pleura here. Okay, just some examples. However, to quantify pleural effusion, everybody wants to quantify pleural effusion. However, ultrasound is not very good. There are a lot of formulas in literature to do that, but in our experience, none of them is good. Okay, so I like to talk about this paper published in '94, a long time ago, but it's very nice to understand this. For example, if you place your transducer here in the posterolateral region and you measure the distance, the bigger distance of the parietal pleura to the visceral pleura here, and you have this distance, this author tried to correlate the distance with the volume of pleural effusion. Okay, however, you can see there is a big variation. Okay, for example, if you have a distance of 20 millimeters, you have the mean volume of 380 milliliters. However, you have a variation that goes from 150 to 660. So a small amount that may not be symptomatic to bigger amounts which may be symptomatic. This is the same distance, okay? So this is to show that the variation is huge. Here in Brazil, we tend only to subjectively classify in small, moderate, or big. We do not give an exact volume, okay? So to qualify, pleural effusion ultrasound is good. Here an example of nodules in the pleura. This is an example of metastasis. You can also see septa within pleural effusion, which is important to know, because if you're going to punctate this, you have to break the septums. And about the limitations, there are a lot of limitations of lung ultrasound, but this is one I like to tell you, is that the central opacities, central diseases, central findings may not be seen on ultrasound if you have normal lung in between. For example, this is a patient with COVID-19, and these central opacities here, if you place your transducer here, you cannot see the opacities, because the normal lung here will produce A lines in the ultrasound, and you will think that is normal, but it's not normal. So this is a limitation. We can only see the periphery of the lungs. When there are normal lungs in between, you are not able to see the central findings. And to finish, I'd just like to tell another thing. You can also see, evaluate pleural thickening. You can use your high frequency transducer to see if the pleural line is thickened and if have irregularities, which is a finding of COVID-19. This is a case of confirmed COVID-19, and you see pleural thickening and pleural irregularities here as well. Okay, so this is what I had to tell you. Thank you for your attention, and I hope you have enjoyed it.